Welcome, welcome, welcome to Health Issues. I'm your host, Chris Sylvain, and I'm totally excited about today's show, and I know you will be too. We are talking about substance abuse today and addictions and to drugs. Legal drugs mainly. We have actually a distinguished guest, Dr. Jose Artecona. He's Assistant Professor of Psychiatry, Division of Forensic Neuropsychiatry at Tulane University. Welcome, Dr. Artecona.
Thank you.
All right, we're excited to have you, and really, your background is perfect for what we're dealing with right now. Let me just start off with a question up front, and we were just talking about it. We're here talking about addictions, and mainly with, hydrocodone is going to be moved from Schedule 3 to Schedule 2, which means that, there's no refills or whatever, really tightening up on that. But I always step back. We do a lot of things on nutrition here, and I always think about, America and its drugs, and we have a bunch of folk sitting there drinking Coca-Cola, addicted to Coke. If you took their Coke away from them, they'll die. Eating sweets, addicted to that, and again, maybe going to a casino, totally addicted. But then the fact that these drugs are totally criminalized, where doctors, physicians, and patients and so forth end up being victims or criminals. So if you can just give us some groundwork there.
Well, I mean, as of right now, the things that are considered most dangerous or most damaging to one system are the drugs of abuse, like alcohol, opiates, stimulants, and things of that nature. Right. I mean, you're referring to people who have perhaps behavioral addictions or excesses in their behavior, right, as in with food, that can cause tremendous amounts of problems. Generally, that's accepted within a culture, so that's much more difficult to change, whereas drugs tend to be from outside most people's normative or normal level of experience. The American Psychiatric Association typically classifies addictions or dependencies on both substances of abuse like alcohol and opiates, and gambling is the only behavioral addiction that's considered in their diagnostic manual, which is called the DSM, the Diagnostic and Statistical Manual. Some people have suggested that some other behavioral addictions are included, such as shopping, overeating, sex, and things of that nature, but those are still, even internet addictions are considered. There are some considerations for overeating and binge eating disorders, and that can be a problem in the sense that people can consume very large quantities of food. Some people have looked at the fact that the overeating and excessive consumption of substances of any type tend to produce the same type of reward in the brain that drugs and alcohol do. So some researchers are looking at the same pathway, the reward system. And in fact, when for example, there's some experiments that are done with rats that are addicted to cocaine, and they will preferentially press the lever that gives them cocaine and will not eat and will not drink. And very often the reward that's provided by food and by water and by sex or things of that nature tends to be overcome by the use of drugs. So it's all working in a very similar pathway in the brain, which is the reward system in the brain. And that's one of the leading theories as to what happens in addiction, where essentially we're using substances that have tremendous release of very pleasurable neurotransmitters in the brain, and that creates sort of this vicious cycle where you seek more and more stimulation, and then your brain adapts to that, so you eventually require more and more substance to achieve the same effect.
Awesome, unbelievable. So it's actually the pleasure reward. I used to work in a drugstore where we'd have Coca-Cola on sale. I hate to use Coke, but A-Cola or whatever, it doesn't matter, but Coca-Cola, all right, on sale. And I mean, people would die for this. They would have to have it. If you took it away, it would be like prohibition.
Yes. And I practiced medicine. I mean, part of my residency training, I did quite a significant amount of medicine. And I saw a lot of people who would have diabetes, have very significant medical problems associated with their consumption of certain foods, and it would be extremely difficult to get them to change their behavior, to get them to change their diet. And it would often lead to very catastrophic consequences, such as loss of limbs and very serious problems that, for example, untreated diabetes or out-of-control diabetes can lead to.
Interesting. It really, really is. So this, if you can touch a little bit more about this reward center, and it just releases these neurotransmitters, and not to go too deep, but I think it's interesting to.
Well, there's a part of the brain called the limbic system, which is, some people call it the reptilian brain or the old brain, which is essentially the big part of the brain. The two lobes stand on top of that, and that's sort of what we have developed over time. And the part of the brain that makes decisions and plans and things and those like that, that's typically that part of the brain. The reptilian brain is a much more emotional brain, or much more instinctive brain. And that's really the part where a lot of substances of abuse seem to have their main effect. I mean, both stimulants like cocaine and methamphetamine, alcohol, opiates, they all eventually hit this little part of the brain called the nucleus accumbens, and they produce tremendous feelings of reward. And as I said earlier, I mean, there's been some studies that would suggest that certain behaviors, such as gambling, tickles the same area of the brain, and it produces a tremendous euphoria. If you do that long enough, the brain will adapt to it, so you require more stimulation, and that's when a lot of problems can arise. And for example, the American Society of Addiction Medicine sees it as an adaptation of the brain, which leads to addiction. So the use of drugs and the continued use of drugs and or alcohol or substances of abuse can lead to this type of adaptation. And some people think that that is what addiction is, this constant seeking for that pleasurable stimulation.
Now, all right, now let's look at the community. So if somebody is, depressed or down or whatever, they're unfulfilled in their life, that makes them, is that a higher tendency to desire that fulfillment from the drug?
Well, the people are much more susceptible to falling prey to the psychological effects of a particular drug. I mean, generally, when you look at people who end up having problems with drugs or alcohol or becoming dependent on a substance, generally you look at two ends of a spectrum. Some people are very genetically predisposed. You can look at their families, and they have a long family history of alcoholism or substance abuse, and they seem to have a genetic predisposition to react differently to substances of abuse, which in turn leads to the potential for abuse and dependence. On the other hand, you have a lot of people who have, like you said, depression or anxiety, or they have other mental issues of living in today's world, which is highly stressful, and they find that these drugs provide some type of comfort or relief. For example, alcohol has always been considered the social lubricant. Most people like to go to a party and they have a couple of drinks, and all of a sudden they start talking, they feel more comfortable, they feel more at ease. Or perhaps for somebody who has a greater level of anxiety, they become dependent on what the drug can do for them. And because it works. I mean, it really does work. The problem is that they start using the substance over and over and over again, and that'll eventually create its own set of problems, because they can become either psychologically or physiologically dependent on the substance of abuse. Those are the two main models, although there's also other facts that come into play depending on your environment, social pressures. I mean, the fact that, for example, in lower socioeconomic strata, there's a greater incidence of drug use, crack. There's a whole subculture of people who are glorifying the use of drugs, and there's all those peer pressures that come into play. Plus, it's also a source of financial support for a lot of people. So there's a lot of factors that are not just part of the individual, such as the genetic predisposition and the using of the substance to alleviate or address perhaps psychological problems. But there's also social and cultural and economic and environmental factors that come into play. So it's a very complicated.
Really? But so if we look at Louisiana, the most incarcerated state in the world, all right, and so drug use kind of, so there's a socioeconomic part to it, but my understanding is there's not a racial part to it, that Caucasians use drugs probably at a higher rate than African Americans and Hispanics or whatever. Is that?
There's varying views on that. I would have to agree with you. I mean, I think the lower socioeconomic is probably the greater impact, although some people would argue that there may be some racial components to it as well.
Okay.
I think it's mostly the socioeconomic, living in cramped quarters, not having a lot of options for one's future. Those tend to be very difficult people to treat. I mean, sometimes when you treat people with substance abuse problems, you want to replace, you want to give them a future, you want to give them a hope for the future so that they can have something to live for, and you try to help them rehabilitate themselves. Okay. And in some cases it's very difficult if somebody doesn't have an education, comes from very limited background as to their future potential and things of that nature. So yeah, I think the socioeconomic factors that come into play are very important.
Yeah, I always throw that out because we've done a lot of shows and will continue to, because African American males are incarcerated at a rate, I don't know, 100 times more than any other race, but the actual incidence of drug use is actually less. So that's a criminal justice issue, but I think it's something that kind of ends up being validated right here as we speak. Yeah, that's important. But so is the person who uses drugs always a victim?
No, it depends what we're talking about. I mean, there's a lot of people that use drugs recreationally. They use alcohol recreationally, or they use marijuana recreationally. I mean, it's part of the culture. I think I was reading some statistics. I mean, 12 million people last year used narcotics non-medically, and just for recreation. I mean, I see a lot of kids that come into treatment these days, and whereas 10, 15 years ago, the drug of choice would have been cocaine or would have been heroin, now you see a lot of kids that are coming in for prescription painkiller abuse. The use of prescription painkillers has skyrocketed in the last 10, 15 years. And the deaths from opiate use have tripled and quadrupled. Emergency room admissions, seeking treatment for substance abuse. So it's become a big problem.
Well, tell us, we talked about it before. Tell us a little bit about where we were from '86 to where we are now. At first they opened the gate, and now they're closing the gate.
Now they're closing the gate, yes. And just so you know, so a lot of people these days, it's part of the culture. So oftentimes if somebody goes to a party and they're going to use a substance of abuse, very often a Lortab may be offered to them, or a Percocet, or an Oxycontin, or things of that nature. So, and not everybody that uses a drug will become dependent or addicted on it.
Is it half or a quarter, or any numbers on that?
The prevalence, roughly 10% of the population, roughly, ends up having a substance use disorder. About half of those, maybe about half of those will become dependent, where they have very serious problems, and the rest will have potentially abuse problems. On top of that, a very large percentage of the population will drink socially, or will use drugs socially, will smoke marijuana socially. I mean, we're seeing a burgeoning of states that are legalizing marijuana, so large quantities of marijuana are being smoked legally all over the place. So that'll create its own set of problems. I think we talked earlier about alcohol, for example. I think if alcohol was a new drug today, it would probably be banned by the FDA.
Right,
but the fact that it's been culturally sanctioned and approved is just something that we've learned to live with.
Wow. How do you distinguish between the recreational drug user and the guy who hurt his leg and he started on 60 tablets of hydrocodone and he falls into that 10% range, where he can't stop?
Well, you need to look at a particular history to address who's who. Most of the time, the person that took the 60 hydrocodones and couldn't stop will be seeking more hydrocodones and more hydrocodones. After a while, they very well start doctor shopping. They may start buying drugs off the street. Mm-hmm. They may start doing drugs differently than prescribed. They usually start by taking much more medication than prescribed. Mm-hmm. They start seeking ways of getting greater effect, so they may start insufflating or snorting the medication, or even using it intravenously. Very often, people who become dependent on opiates, very often they'll graduate to heroin because it's readily available, particularly if there's their connection or their supply of oxycodone or similar narcotic is no longer available. So it can lead to a significant amount of problems. Why some people develop the addiction versus others? As I said earlier, I mean, part of it is genetic makeup. Part of it is the fact that they may have some psychological issues that are being addressed by the drug, so perhaps they start becoming psychologically dependent on the drug, and that'll eventually lead to a physiological dependence when it comes to opiates. Mm-hmm. There's also financial gain. Some people sell their drugs, so it becomes a very difficult thing to deal with. There's also some unscrupulous practitioners that prescribe large quantities of these drugs. Mm-hmm. I mean, they're the so-called pain mills, mm-hmm. where people just go in and they just get prescriptions in exchange for money, mm-hmm. Without really there being a true medical workup or medical need for it. I mean, I read a very scary statistics that 80% of the narcotics prescribed in the United States are prescribed by approximately 20% of practitioners. So a relatively small subset of practitioners are responsible for a very large amount of the available drugs that are out there being abused today.
Well, let's look at the patient who, part of that 10% who gets addicted quickly. And I say 60, it can start off with 12 pills. Or 10, it doesn't matter how many they start with. Mm-hmm. And I guess two questions. The first one, though, is the legitimate physician. What should they do? This patient does have chronic pain, all right? They're constantly in pain. There's no other class of drugs, so what should they do? There's
a number of things that a legitimate physician can do. First of all, to mitigate the potential for danger. One of the things that's available in the state of Louisiana is a prescription monitoring program, whereby you can keep track of anybody who is doctor shopping or getting prescriptions filled in different pharmacies or going to different doctors to get their prescriptions filled. So one of the things that you can do is to monitor your patient's use of these medications. You need to enter into a contract with the patient that you're going to be the sole provider of treatment for them. During performing urine drug screens is very, very effective because you can see whether somebody is abusing other substances or whether somebody is actually using the substances that you're prescribing. Very often people may be looking for medication so that they can make a profit. And if you have somebody that you're prescribing a particular medication to and then you do a urine drug screen and it turns out that they're not on the medication, then that's a red flag that this person may be diverting. Other things that people do is they sell their prescriptions, they share their prescriptions. You can look at patterns of behavior. For example, very often people who are abusing drugs are running out of medications early. Their prescriptions suddenly get lost or get stolen. So another thing to mitigate is to contract with your patient and to say, look, this is unacceptable. I will not keep refilling your prescriptions. You may give them a one-time only grace loss prescription thing, but then after that, you make very clear boundaries that this is unacceptable behavior.
But all right, and as a researcher, as a physician that teaches this, physician's physician, most physicians are caught in the shades of gray because that 10% is a huge patient base.
It's a huge patient base.
A huge patient base. You literally, because it's the #1 prescribed drug in America. You're talking about opiates.
And right? they tend to be very demanding, too.
Exactly. So, but the thing of it is that not not the idea, again, we're speaking about the legitimate physician. You know, we know illegitimate, let's kick that out the window.
Sure.
Okay, lock them up, throw away the key or whatever. The legitimate physician, the idea of addiction is not clear-cut either, all right, because they're in chronic pain.
Yes.
And opiates still ends up being the drug of choice, all right, for the most part. So the physician is playing a cat and mouse game that goes on for years. And which should the physician do?
Well,
not if, again, if it's not a total diversion issue, you're not dealing with selling and all of those sorts of things. The patient is just in chronic pain, and they build up tolerance, and they need more of the drug. And
well, at some point, there are many things that you can help somebody learn to cope with a certain degree of pain. You can look at their functional abilities. In other words, the goal of proper analgesia or proper pain management is to return somebody to a functioning life, not to have them become totally dependent on a drug. Sometimes that may necessitate learning to live with a certain degree of pain, perhaps not a lot of pain, but some. There's physical therapies that can take place. There's diet. There's exercise. There are things that people can do to help them get mobilized and to help them be functional. You can put limits on the amount of medication that somebody, especially in non-cancer, non-malignant pain. You have certain conditions that will require increasing doses of medication because people become adapted to a particular substance. But when you're working with somebody with chronic pain, you have to draw the line at some point to provide proper analgesia at the same time that you're allowing for functionality.
Well, and that becomes a question. Is there a system in place for physicians, at least to, you're speaking about physical therapy, diet, and exercise?
Sure. None
of the three are fun compared to the pill.
Absolutely. And people can become very dependent on the pill to cure all their ailments. If people have psychological issues, for example, they could be amenable to counseling. They can be amenable to psychotherapy. So there's a lot of things that people can do. There's alternative approaches like acupuncture and heating pads and things of that nature. So there's a lot of things that one can do if they're motivated to help alleviate the pain.
Okay.
And also learning to accept to live with a certain degree of discomfort. In other words, changing the mindset from being completely free from every little bit of pain that there is.
Okay. Is there a system in place, you know, and you guys over at Tulane, is there a system in place to help physicians move people from opiates to diet, exercise, physical therapy, those types of things? I don't see a system in place.
No, as far as I know, there are guidelines that people, suggestions that are given.
Yeah, it's just no. I mean,
but
the answer is just no, but there's nobody holding the physician's hand to help them traverse this big Grand Canyon.
Yeah, but although I think that ethical people who work in pain management have put a lot of these things into play. They know what to look for in terms of people who may be abusing medications, in terms of people who may be becoming very dependent, and they have ways of kind of curtailing that and mitigating the damage. Some of the things that I've said, you look at prescription monitoring, you look at any sign that this person may be using the medication inappropriately, and you may intervene. Sometimes you may send somebody to drug treatment, to help them kind of just address when things have gotten totally out of control, and then from there start working on the pain management.
Would you be a proponent of, and it would be from you guys' area, you know, I think top research university in the country, one of the top ones, looking at creating some type of system for physician training, you know, to help. Because what happens is that the line of demarcation between the great pain specialist in a pain clinic and the general practitioner is a huge gray area, where the general practitioner thinks that they're doing, you know, a good job, but the pain specialist, is not a whole lot of difference between the two of them, because neither one of them, rarely do you see anybody moving into this whole idea of pulling people away from opiates. That's a rare thing in America.
And that would be a very difficult thing to do. There's another thing called buprenorphine, which is a partial, it's one of these medications that will provide analgesia, but to a particular point. And sometimes if you can switch over to somebody to that medication, that can also maybe help prevent the abuse of opiates.
I think it's a discussion that needs because what's happening to me is a zoo. What's going on now? You know what I mean? There's no firm guidelines or limits or training for the physicians that are out there, and it's still the #1 prescribed drug. And so now the FDA is coming with the hammer approach. But what about the physician themselves and their professional judgment at this point?
Well, I think education is extremely important. Some of the things that I've talked about today, a lot of physicians are unaware that they even exist, such as a prescription monitoring program. I don't know how many physicians are using that. I do think that there's a lot of pain management specialists that are very aware of this issue, and that they have within their area of expertise, they really have established certain guidelines to look for, to try to mitigate or ameliorate the possibility that people may be abusing the medications to such an extent.
We have a couple of minutes left. Now, for all of this, you know, a lot of physicians watch this show, but for the patient, how do they know that they're going to a good pain specialist or if they're going to a quack?
Well, if they do proper medical workup, if they talk to them about what's going on with them, if they provide some of these other sources of relief, if they want to make sure that their pain is adequately controlled, but they're looking at the whole person as opposed to just quickly prescribing medications. I mean, that would be one of the telltale signs that you're going to somebody who's more reputable in terms of their as a practitioner.
Okay, now let's flip it around. So the patient's looking for a reputable physician, but they're still trying to deal with the tolerance to the drug, so they don't even want a more reputable physician.
Well, that's a separate issue. That's somebody that doesn't want to have the reputable physician and somebody that's looking for continued use of possibly large quantities of opiates.
Is there a system in place that identifies reputable from unreputable?
I think anybody who is certified, there's a lot of proper anesthesiologists that are certified in pain medication. There are some psychiatrists that are also certified in pain medication that I would certainly look for.
But is there a seal or something, certified in pain, or, you know?
Yeah, there's a...
Because a whole bunch of doctors say they're certified in pain.
Yeah, you have to look under a board of anesthesiology board, and they can give you what the proper credentials are.
That's pretty deep.
Yeah.
The average guy to go into. Awesome information, and we appreciate everything that you brought forth. We got a few more seconds. Any general words you'd like to help educate the people at this point?
If somebody thinks they have a problem, there's always help available. I mean, I think there's very reputable, there's treatment that's available, and there's ways of dealing with chronic pain, even if you have a dependence, that are available to people. There's also self-help fellowships. Hey,
Chris Sylvain, Health Issues. Look, you have to learn. Work as hard as you can. Ask somebody, and they can help you. Health Issues. I'm your host, Chris. Thanks so much.